Welcome back to CCRN Review Respiratory Part 4. Let's keep moving. In this section here, we're going to first start talking about bronchiolitis. So bronchiolitis is a respiratory condition that happens typically in infants, and it's usually caused by RSV. This may be a precursor to later asthma, so that's something that we want to keep in mind because this may be something that we'll have to pay attention to later on. Risk factors for severe illness include the very young, immature or premature infants, chronic lung disease, congenital heart disease. Again, these are going to be sick kids to begin with, and then they get the RSV and end up with bronchiolitis. Assessment, tachypnea. Apnea is possible in infants, so we may see periods of apnea. Tachycardia, fever, grunting, nasal flaring, retractions, wheezing, dehydration, a history of upper respiratory symptoms. So typically this is what precedes the actual infection, is that we'll see this period of time where the patient has the runny nose, the cough, the progressive dyspnea, and then that's moving into the RSV. Treatment is going to be oxygen if the patient's hypoxic. Okay, so again, we're trying to move away from using oxygen for every patient that is short of breath. A lot of times the shortness of breath is going to be a function of the other pieces that we need to treat. Bronchodilation, steroids, etc. So we're going to do those kind of things to try to treat the hyperventilation and so on. But we don't want the patient to be hypoxic. So if the patient's hypoxic, we will use oxygen. Antiviral agents are helpful, and IV fluids. Asthma is another one of the conditions that the AACN wants us to know about. And what this is showing here is the process that occurs with asthma. So you can see up there at the top we have this initiating factor. There's some kind of initiating factor, and in most cases with asthma, it's going to be allergy, and that allergy then stimulates inflammation. The inflammation then stimulates bronchoconstriction and mucus production, and some of our patients will then go on to develop severe asthma. Not all of them, but some of them will go on to develop severe asthma. So we need to be able to identify who those patients are that may progress down that road and end up in severe asthma so that we can try to prevent that. Some of the risk factors for severe asthma include previous severe asthma attacks, hypercapnia, airway hyperreactivity, long-term steroid use, age. The very young and the very old have less control over their immune systems, non-compliance, psychiatric illness. So all of these things are risk factors for severe asthma. So again, when you're taking a look at that asthmatic that you're caring for, we want to look for some of these pieces to help us to be aware of who might be at risk for having that severe attack. Now, the severe attack, severe asthma, when we talk about that, we're talking about somebody who needs to be intubated and go to the ICU, as opposed to somebody maybe who's come into the ER, needs a few nebulizer treatments, and boom, they're out the door. So some warning signs of a severe asthma attack include subjective increase in dyspnea, increases in sleep disturbances, okay, because there is a circadian rhythm, a 24-hour rhythm to our lung health. During the evening times at night, we have less of the hormones in the body that are going to allow for bronchodilation, such as cortisol and epinephrine, etc. So we have less of those at night, so we're more prone to getting bronchoconstriction during the evening or night hours. So we may see that evidenced by sleep disturbances, nocturnal bronchodilator use. The patient wakes up and they have morning chest stiffness or heaviness because they were breathing hard in their sleep and using different accessory muscles, etc., while they were sleeping because they were trying to breathe through this bronchoconstriction. So notice that a lot of this stuff happens at night. So we want to ask them about their breathing at night and how they feel in the morning. Symptom-wise, well, we have this immediate bronchoconstriction. This is called an early phase reaction. So let's say that we've got somebody who comes in contact with an allergen. Maybe it's, it's nice outside, so they go outside and people are mowing their lawns and they're allergic to grass. And so within minutes, they are having this early phase reaction and getting some bronchoconstriction where they have to grab their inhaler and have to puff on the inhaler a couple times to open back up again. That's the early phase reaction. There's also a late phase reaction that can occur days later. So having had that initial contact, even days later, they can have a reaction to it. Dyspnea, tachypnea, tachycardia, wheezing, obviously that's going to be one of our cardinal signs. Sputum may be yellow due to the increase in eosinophils that are being released into the lung to try to overcome this allergen and this inflammation. Accessory muscle use and orthopnea. Diaphoresis may be present. We will probably see a decrease in the FEV1. That's a forced exhaled volume in 1 second. And the forced vital capacity, so the FEV1 and FVC ratio. We may see a pulsus paradoxus. We've talked about that earlier when we talked about pulmonary emboli, how the blood pressure is changing with the patient's respiration. In this case, it's because we have too much air getting trapped. The patient's getting some air trapping from this asthma, and they're actually getting some positive pressure in the chest. Increase in PAP, if we happen to have a patient who has a Swan-Ganz catheter in place due to vasoconstriction and alveolar overdistension. Shunts develop. We get hypoxia, hypercapnia as the attack progresses. This is the part that we call severe asthma. The patient with hypoxia and hypercapnia is the patient that we call severe asthma. So we got to be careful. Once we get to this point of hypoxia and hypercapnia, this patient could decompensate very quickly. So bronchodilators, we want to open this patient back up. The picture at the right is showing what it might look like in a patient who has asthma. Notice that we not only have that decreased airflow because of the airway hyperreactivity, but we also have secretions. And those secretions are also blocking the airways. So between the combination of secretion and the bronchoconstriction, we end up having a very narrow or even blocked airway, making it very difficult for that patient to be able to breathe. So we want to open that back up. Some of those medications that do that, the beta agonists, such as your Preventol and so on, anticholinergic medications, steroids. Steroids help tomorrow. Okay, the other bronchodilators help today. So steroids decrease inflammation. It's going to take a while to decrease the inflammation and allow those airways to open back up again. IV magnesium. Remember, magnesium causes relaxation. So if we're giving magnesium to the patient, we'll also get bronchial relaxation. So it'll relax the bronchi. However, magnesium also has a lot of cardiovascular effects, right? So we don't want to be just giving magnesium willy-nilly to our patients. We're going to be giving it to those patients who are unresponsive to our other treatments. And then antibiotics. Oftentimes, asthma is going to be there's going to be an underlying infection that is stimulating this asthma attack. Assisted ventilation, well, in patients who have asthma, we may try some BiPAP. However, BiPAP typically doesn't work very well in our asthmatics. So there are some studies that show that there is some improvement with BiPAP. Other studies show that we're not having great effects with BiPAP. So it might be something that your physician wants to try. Oral intubation is typically going to be recommended in asthmatics because asthmatics frequently also have a sinusitis that is associated with their asthma. Sedation with propofol may induce bronchodilation, so that may be a good thing to also help to reduce the amount of resistance. Avoid the paralytic agents because we can end up with myopathies as a result of the steroids that we're giving along with this. The National Asthma Education Program says that we should provide patient education to our patients to reduce the ER visits and hospitalizations. So we've actually found that there's been a dramatic decrease in hospitalizations when we have given enough information to our patients about how to avoid these allergens and how to maintain their asthma so that they're not having recurrent bouts with it. Patients managed by allergists had fewer hospitalizations and ER visits. Okay, it's got an allergic basis to it. So if we have an allergist that is managing this patient, chances are very good that we're going to have the allergy better under control, and then we're not going to have as many hospitalizations and ER visits. Immune modification may be necessary. Okay, so the patient may need IVIG or some other immune modification in order to be able to control the asthma. Allergy control, so maybe allergy shots or controlling allergy with some medications. Patients who are exposed to cats and dogs in the first year of life had less incidence of asthma. So isn't that interesting that it looks like they built up a little bit of immunity of some sort to having allergies by being exposed early on. Patients who are not exposed to dogs and cats in the first year of life, so what's happening with them is that they don't build up that the recognition, I guess, of these different things that, the dander, etc. And so they end up having more allergies and more asthma. So this diagram here, it's showing our total lung capacities. We've seen this in a different way before, but moving across the middle there, we have the tidal volume in the light blue. We have our maximal inspiration, maximal expiration. We looked at those before. Then we have our residual volume. Okay, you see the residual volume down there. That's the part you can't exhale. Put that together with our maximal expiration. So those are the two pieces we don't usually exhale, and it's called our functional residual capacity. Our vital capacity is the total amount that we can inhale and exhale. Okay, so that's that first purple bar there, vital capacity. Inspiratory capacity is our tidal volume plus our inspiratory reserve, and then the total lung capacity is over on the right-hand side. So when we're talking about some of these different pieces here with our asthmatic, this is something to keep in mind, is the different areas that we're talking about. So we're talking about our functional residual capacity versus our FEV1. We're talking about looking at our functional vital capacity. Okay, that's that purple there. The total amount the patient can inhale and exhale versus how much they can exhale in the first 1 second. So this tells us about how much air the patient's moving and how fast they can move it out. That tells us about bronchoconstriction. Hemodynamic effects of breathing. This is normal breathing here. So we have a normal breath where the diaphragm drops, chest wall expands. We have negative pressure that's pulling the air in. And then on exhalation, you see the diaphragm is relaxing. And interestingly, the diaphragm, when it's relaxed, is curved. So you see the diaphragm in its relaxed position there, in the exhaled position, it moves up. The chest wall then relaxes and contracts, and then the air is pushed back out. So this is what we have normally. So we have negative pressure in the chest at all times, a little tiny bit, and then it gets to be greater during inspiration, and that's what sucks the air in. Our non-invasive positive pressure ventilation, that includes both our CPAP and our BiPAP. So when we're talking about non-invasive positive pressure ventilation, we're talking about that ventilation that allows the patient to be able to get the benefit of positive pressure, but not have to be intubated. So CPAP and BiPAP. CPAP gives a positive end expiratory pressure. End expiratory, what does that sound like? That sounds like PEEP. CPAP is PEEP for our spontaneously breathing patients. If your patient is intubated and on a ventilator, we call it PEEP. Same thing, it's end expiratory pressure on either case. And what it does is it helps to prevent our alveoli from collapsing. Again, when we're blowing the lung up with air, think about it like a balloon. You blow a balloon up, it expands, you let go of it, it contracts and it goes, flat. But if we're breathing naturally and normally, remember we have negative pressure, it's like grabbing the balloon from the outside and pulling it open from the outside, then it never fully collapses. When we start to ventilate our patients, or our patient has disease, those alveoli can start to collapse. So that's why we'd use end expiratory pressure. Think about what that means, end of expiration. So the air is all coming out, very end of expiration, we have those alveoli collapse. That's when we provide some pressure. So the pressure is holding that open. BiPAP is CPAP, plus it also provides an inspiratory pressure. So it's giving the patient a little bit of inspiratory pressure. Now, maybe you heard of that before when you're working with patients on a ventilator. It's called pressure support. So basically what BiPAP is it's CPAP plus pressure support, or PEEP plus pressure support. So how do we decide what we're going to use for our patient? Well, this is a little guide here to kind of run through and think about how we're going to be using our assisted ventilation. So is the therapy going to be less than 48 hours? Yes. Okay. Well, maybe we can use a mask. Is the work of breathing increased? If it is, then we go to BiPAP. If it's not, we go to CPAP. If the therapy is going to be greater than 48 hours, we probably need to intubate and use mechanical ventilation. Now, there's other things that we have to consider here. That's the very first question. Is the patient able to maintain their airway? Thoracic surgery is another one of those sections that's on the CCRN exam. Keep in mind, they don't want you to be a CVICU nurse, okay? So they're not going to ask you those kind of questions, but they want you to have an idea about what cardiac surgery is about, so that if you're caring for a patient on a general med-surg type of ICU floor, that you're going to be able to manage this patient. Okay, so or maybe the patient's coming back to you in the medical ICU or even the surgical ICU for some other reason, but they've had thoracic surgery. So one thing to be aware of is with thoracic surgery, when we open up that chest wall, we lose that pleural pressure. Remember again, we said there's that vacuum that holds the lungs open. Cut into the pleura, the lung is going to collapse because we have that negative pressure pulling it open. We have the loss of elastic recoil of the lung. We have inflammation and fluid formation. So a lot of things happening there that are going to potentially lead to additional problems down the line. And this is why we put chest tubes in. So when patients have thoracic surgery, very common for them to have a chest tube afterwards because they have that loss of pleural pressure. So it's thoracic trauma, lung mass, lung reduction, surgeries, transplants, biopsies. These are all reasons why we may be doing thoracic surgery. Another type of thoracic surgery, one that's used very commonly now for things like lung biopsies, etc., is called a video-assisted thoracic surgery, VATS. It's obviously less invasive. You know, everything nowadays that's laser and everything else is less invasive. So it's less invasive and there's a shorter recovery time. However, whether it's an open thoracic surgery or a video-assisted thoracic surgery, we want to make sure that we are providing great pulmonary hygiene for our patient afterwards, because the lung is obviously the spot that's going to be affected the most. During this surgery, the lung was deflated. So in most cases, the lung will be deflated because we're working on the lung, or even if we're working around it, we may have to have the lung deflated so it's not in the way of other things, maybe the heart, etc. So the lung may have been deflated. If not, it was on mechanical ventilation and we lost the pleural pressure. So there's going to be lung potential issues as we move forward. The other potential issue would be with the heart. We could be developing fluid around the heart or air around the heart. So we want to be listening to those lung sounds and those heart sounds. Watch for pulmonary complications, watch for bleeding, watch for infection. Okay, again, thoracic cavity here. You see all of the different components, and you see that there's no extra room. If there was extra room in there, all this stuff would slosh around. Okay, so as you're running, your heart would be sloshing around inside your chest. Your lungs would be flopping all over the place. Okay, so there's no room in there for anything else. If we get some bleeding in there or some air, some fluid accumulation, it's going to compress something. It's going to compress the heart or the lung. It's going to compress something and create additional complications. So we want to be listening to those heart sounds, those lung sounds, and making sure that we're not getting any additional complications, a pneumothorax, hemothorax, pleural effusion, any of those kind of situations. Thoracic trauma is another piece that we have to be aware of. Thoracic trauma, I think, is best, any kind of trauma, is best thought of by thinking about a balloon. If I blow a balloon up with air and I throw it against the wall, it's just going to bounce. But if I poke it with a pin, it's going to pop. This is similar to what happens with trauma. Blunt trauma to a hollow organ typically is not as damaging as penetrating trauma is to a hollow organ. However, let's fill that same balloon up with water and throw it against the wall, and what happens? It bursts all over the place, right? However, if that balloon is filled with water and we poke it with a pin, what happens? It just simply drips out and leaks. So it's similar to what happens with solid organs and trauma. Blunt trauma to a solid organ typically makes it explode. Penetrating trauma, it just leaks. So when we're talking about the different types of organs, we need to be aware of whether it's blunt trauma or penetrating trauma, because one or the other is going to typically be worse for that type of organ. So first of all, let's talk about the lungs. Lungs are obviously a hollow organ. So blunt trauma is going to just basically make it contract, etc. I mean, it's not typically going to burst a lung. However, what can happen is that we can get bruising to the lung. Remember, the lung is very vascular. So we can get some bruising occurring to it. That's called a pulmonary contusion. And when we get a pulmonary contusion, it's going to cause capillary permeability. Remember this whole inflammatory process. So the inflammatory process here is going on because we had that blunt trauma. So fluid leaks out of the pulmonary capillaries into the lung, and we get pulmonary edema. However, this pulmonary edema can end up being very thick from inflammatory debris, damaged cells, and just the fluid that's leaking out. So we can end up having some thick pus-like fluid, and that can really start to disrupt our alveolar capillary membrane. The best way to treat this would be to put some positive pressure in there. So how are we going to find our pulmonary contusions? Look for the contusions on the chest. So we're looking for some kind of blunt trauma that's going to be pretty big, like a motor vehicle accident. And we're looking for contusions on the chest, tachypnea, dyspnea, blood-tinged sputum, possibly increased airway and peak pressures, decreased PaO2-FiO2 ratio, because we're starting to interfere with that alveolar capillary membrane. This is a patient here who has a pulmonary contusion on the right. So you can see that they kind of got that whiteout going on the right side there. Lots of fluid is being lost into the lung tissue. The left side looks pretty good. We got a nice dark looking lung there. So lots of air in the lung, but the right side, you can see that there's a lot of fluid in there. And there's some fractures of the ribs. So pulmonary contusion, the best way to treat this is intubation and ventilation, and add some PEEP on there. Let's get some positive pressure in there. That'll help to keep the fluid from leaking into the lung. Remember, the lung is a negative pressure environment. In other words, a vacuum. When you take a breath in, you're creating a vacuum. You're creating suction. It's pulling fluid into the pulmonary, into the lung, into the pulmonary tissue. So if we intubate and ventilate, we're putting positive pressure in there, push it back out. Okay, so that would be the way that we'd want to treat this pulmonary contusion. Watch for infection. Okay, we got fluid sitting around in there. This patient's had trauma. If we have to intubate and ventilate, of course, that increases the risk the patient could develop an infection. So watch for infection. ARDS, multi-organ dysfunction, is a possibility as well, with the additional trauma that comes with most pulmonary contusions. So unless this is an isolated injury just to the chest, we may end up having ARDS and multi-organ dysfunction. Rib fractures. We have simple rib fractures. That's just one rib that's fractured, maybe even two ribs that are fractured in one place. Not a big deal, except we have decrease in ventilation. Most of the time, it's just due to pain. The rest of the ribs can move the lung tissue fine. We don't have any problems in moving the lung, but the problem is that the patient doesn't want to take deep breaths because they have this broken rib that hurts. Multiple fractures can result in flail segments. So this is the part that we really have to be concerned with. Also, if it's a first rib fracture, we're looking at great vessels, and we're looking at our C-spine. Lower rib fractures, 7 to 12, we have to be looking for abdominal injuries that are associated with it. So here you see we have multiple ribs fractured. I highlighted them with a red circle around them, but you see we have multiple ribs fractured here, and these are fractured in more than one place. So they're fractured on the front side here. You can see the front fractures and not the fractures in the back. But what's going to happen in this situation is because these ribs are fractured in two places, and it's multiple ribs, that means there's a segment of the chest wall that is no longer connected to the rest of the ribs, and that is called a flail chest. Look for signs of contusion. Look for pleuritic pain, decreased respiratory effort. Physiologic splinting is basically what we'll do for most rib fractures. Most of the time we don't use rib belts or any other type of way of supporting those ribs just because of the possibility of decreasing our respiration even further. If there's multiple fractures on a rib, they may do a surgery and just kind of tie those ribs back together a little bit. But in most cases, we just let them heal up on their own. Okay, so this is what's showing the situation I was just mentioning about a flail chest. So if you notice in the top picture there, you see how that whole segment of ribs gets sucked in with inspiration. So as a patient inhales, the negative pressure in the chest sucks that section of ribs in. Then the patient exhales, and that section of ribs is pushed out. And here's the problem with that. Take a look at those arrows. You see the arrow up on the top picture, it says C and D. It's showing that air is not only moving back up the trachea, but it's moving across to the good lung. Then as the patient exhales, air is moving, okay, look at the bottom picture, and you see B and A. So air is moving back from the good lung to the bad lung. So we have air movement moving from one lung to the other instead of in and out. This is going to lead to hypoxia real quick. So symptom-wise, we're going to see pleuritic chest pain, dyspnea, deformity, crepitus, hypoxemia. This is another picture here of a patient who has a flail segment. The broken ribs are designated by the little red arrows. Treatment is oxygen, ventilation. We may have to stabilize that with tape, but in most cases what we'll do is just put the patient on the ventilator. So change this to positive pressure ventilation, and now we're able to ventilate both lungs. In some cases, if this flail area is just moving so much, we may have to go in there and tie those ribs down a little bit with some wire, keep them in place. Complications include pneumothorax, atelectasis, and ARDS. Well, thank you for joining me for our CCRN Review Respiratory. This was part 4. Let's move on. You are doing so great. Let's just keep going. And remember, if you have questions along the way, feel free to reach out either in the comments below or send me an email.